This is Brent of the Brookbush Institute, and in this video we're going to go over manipulations or high velocity thrust techniques. I assume that if you're watching this video, you're watching it for educational purposes and that you are a licensed professional with high velocity thrust or manipulation techniques in your scope of practice. If you're not sure, check with your state board. Most physical therapists, chiropractors, and osteopaths, you're in the clear. I believe that ATCs, you can't do manipulations in the United States, although other countries. Again, check your scope. Of course, massage therapists and personal trainers, these are generally not within your scope. Of course, you could continue to watch these videos just for educational purposes, learn a little anatomy, learn a little biomechanics. If you're going to do these techniques, please make sure that you have a good rationale for putting your hands on a patient. This should be based on assessment, and if you're going to assess, I'm hoping that you'll assess, use these interventions, and reassess to ensure that you're getting the result that you're looking for and have good reason to continue using this technique. In this video, we're going to go over cervical manipulation, or at least mid to lower cervical manipulation. I'm going to have my friend Yvette come out. She's going to help me demonstrate. Now, if I'm doing a cervical manipulation, we do have to keep in mind that I'm basing this on more than just subjective complaints of neck pain. We can have neck pain for hypermobility of cervical segments. If we're doing manipulations, it should be for hypomobility or some sort of restriction. So I'm going to base this on some sort of assessment for range of motion. For example, we could do our visual exam of rotation, lateral flexion, flexion, and extension. I might try to add goniometry. Keep in mind the only reliable goniometric assessment for the cervical spine is actually lateral flexion, and you guys can look that video up. Now, you might want to continue with some special tests if you're going to do this. The VBI and ligament tests are often brought up as necessary before doing a cervical manipulation. That's probably more dependent on what your liability insurance states or what insurance companies you're working with state have to be done. And the reason why I say that, guys, is there is very little evidence to suggest that those tests themselves are particularly reliable or that they would give us any indication of somebody who could be hurt by a cervical manipulation. So I think cervical manipulation injuries are rare, and that's possibly the most important thing to keep in mind. If somebody does look like they need this technique due to a mobility restriction, you should probably move ahead and do so with care and obviously with practice. And we're going to try to show you guys some pretty conservative techniques here. Now, after I've gone through my assessments, whether that's subjective, objective, and special tests, including VBI, or it's subjective and objective alone, I'm going to go ahead and have Yvette back off the table here so her head's hanging, so that now I have control of her head and cervical spine. And the next thing I'm going to do is I'm going to use what's called a piano finger grip by like the Maitland School, where I'm going to put my fingertips between her spinous process, right? So you can think of her spinous process are lined up this way, and I'm trying to put my fingers just in between. And what I'm going to try to feel for is, do the spinous process move sequentially, right? Almost like dominoes falling. They should go tick, 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 right? Rather than what you'll feel with somebody who has restriction is you'll get one that moves and then maybe two or three that move together, right? Or you pull into lateral flexion and it's the same thing where you get one that moves and then a bunch that move together. Well, you know those segments that are stuck together are potentially something that could be helped by a cervical manipulation. So I can do this with Yvette here, a little lateral flexion, a little rotation. I can do both ways. And I do feel a little restriction over what's probably between C3 and C5, right? So those two segments. Now, how am I going to manipulate those segments? Well, this was a little confusing when I first got taught it, but I think part of the reason why it was confusing is nobody really helped me understand that the most important thing about a cervical manipulation is finding the lockout position. Finding that position where you have all of the joints locked so that when you do the actual manipulation motion, the only thing that can move is the segment you're trying to move. And that comes down to two big things. Well, maybe more than two big things, but two major things are going to be that you block out the lower segments and that you get in locked position with the top segments. So what we're going to do is we're going to use our second MCP on the spinous process just below the segment we feel restriction. You don't even have to necessarily know which segment that is, to be quite honest. Some people get very detail oriented about, well, I'm manipulating C4 on C5. Or you could just feel for the stiff segment and go after that. Your accuracy is probably pretty similar either way. So I'm going to put this MCP on the spinous process of the lower segment and press it into the articular pillar. Right, so you guys can kind of see, I start to take up some tissue slack by pushing my MCP in this direction. I'm already stabilizing, making sure that those lower segments, when I rotate this side bend or extend, I'm resisting all of those motions at anything lower than this MCP. Once I have that stabilized, I'm now going to use this hand, and you guys can either use an open hand technique, which I'm a little less comfortable with, quite honestly, or you can do head cradle position, right? So now I have her head cradled in my elbow crease there. Most of what she's feeling is like my bicep on the top of her head, right? I can almost control all of it just by doing this, right? I'm literally just cradling her head. So she feels nice and comfortable and stable. And then we're gonna wrap our hand around her chin, but keep in mind, guys, I'm not like yanking on her face, right? So we're just got her all wrapped up so her head's nice and stable, right? And then once she's nice and relaxed, now I can move around a little bit. 90% of this is setup. So I know some of you guys are waiting for me to do the manip. Just show me the manip. We got to get it to crack. That's literally the last 10%. And potentially the least important point, because if you lock somebody up perfect, a lot of times they'll move on you. You'll get a cavitation without even having to do a high velocity thrust. So I'm blocking out those lower segments here, up this way. I'm then going to rotate away. I'm going to side bend towards me. I'm going to extend and flex, right? And I kind of, you can see now, once I rotate, side bend, and extend and flex, then I kind of search. And what I'm searching for is if I push up here, or push sideways here, or rotate sideways here, I'm kind of moving her head in this general direction, guys. Get used to that general direction. You don't even have to think joint actions. So I know you might be taught, well, you got to contralaterally rotate and ipsilaterally flex and extend, right? That's all great, but if you just think about this general motion and this general motion here and get all locked up, which I am right now, now all I have to do is a little lateral flexion and rotation, and I guarantee she's going to go. So, nice deep breath of it. And that's it. Sometimes it is a surprise to patients. Not everybody is used to getting their cervical spine manipped, and I appreciate that Yvette is letting me do this for the first time, because she is not somebody who gets cervical manips done very often. But that wasn't that bad, right?
No.
No pain, right?
No.
And you guys can see I didn't move that much. It was more of a startle response than it was any sort of like pain response. We're definitely not doing like big whips this way or trying to like press in really hard. It's just getting that lock and then just a quick twist. Right? I think you guys have seen chiropractors doing it with the open hand technique, which looks a little bit more impressive, but they just whap, right? Like it's a very quick little technique. All right, so let's try that one more time. I'll show you guys from the other side. I'm gonna use this knuckle. I'm gonna get on the spinous process of the segment just below where I think she's stuck. Now, I could use an open hand technique, and I'll show you guys the open hand technique this time. Right, so I'm still blocking this way, and I'm still kind of thinking about pushing up in this direction because I want to oppose the lateral flexion this way, and I want to oppose the rotation I'm going to do. Right, so I'm trying to keep the spinous process below in position, which means I kind of have to push up and in this way towards the articular pillar, kind of in the direction of my thumb right now. Now I can use this hand, kind of wrapped around. You can see like I got my thumb up to her maxilla here, and I'm just kind of wrapped around her head, and I have some some big hands. So it kind of depends on your hand size too, where you're gonna end up as far as your fingertips. So guys, don't look at my hands and be like, oh, that's how it's got to be. Look, you get your hands where they're comfortable. But if I think about the same direction of motion, yes, we can think about ipsilateral flexion and contralateral rotation and all that stuff. Or you can think of, you're doing this with her head, right? You're doing this general motion with her head, and you can add a little bit of this to get locked out. Once I'm blocked out, I'm here, right? And then she takes a nice deep breath for me. And all I'm going to do with my hands is this sort of thing, right? Because I'm going to push her into lateral flexion and rotation this way, which means I'm going to kind of slide my hand this way to get that motion. How are you feeling about it? Okay? Good. And that's it. Right? Sometimes you get a cavitation, sometimes you don't. Never forget, cavitation does not mean success. Success is performed better on reassessment. The manipulation is the manipulation regardless of whether you got a cavitation. It could be that I didn't get her locked up enough on that particular try, or it could be that I got it. I would still reassess first before I gave this one more try. Be careful not trying to get a cavitation too many times because you think you failed, because what you will do is you'll start to flare people up. We do have to keep in mind that high velocity also means high intensity, and if we keep doing a high intensity technique to a tissue over and over again that maybe is already a little irritable, we could start increasing pain rather than reducing pain. How do you feel about it?
Good.
Why don't you sit up and take a minute and we'll go to the close-up recap. All right, for our close-up recap, I brought out the spine model. I wanted to kind of show you guys some of the stuff we were talking about so you have a little bit better visualization. So if this is the back of the cervical spine that you would be feeling, the first thing you're going to feel is those spinous process. And when I talked about that piano grip, I was talking about putting my fingertips kind of between the spinous process so I could feel them move sequentially, like 1, 2, 3, 4, right? They should just each move as in like little dominoes falling. And when two spinous process move together, that might be an indication that I have a little bit of restriction between those segments. So I use that piano grip for that, right? That's what it would look like from the other side. And of course then I'm rotating and side bending. When I talked about putting my second MCP against the spinous process, realize I'm trying to fit it in this laminar trough, almost trying to put it on these articular pillars. And you can see here the articular pillar is called that because when all these facets come together, they kind of make this like pillar shape. But somewhere between the articular pillar and what this would be called would be the laminar trough is kind of where I'm trying to fit my second MCP so that I stabilize the lower segment. Now if I have a vet go ahead and come back here, I'll try to demonstrate for you guys one more time in a close-up here. But so piano grip, what that would look like on her neck is I would feel my spinous process and then I would just slide my fingers over so I was on the side of my spinous process. And then I can laterally flex and rotate and see if any of those segments seem to want to move together rather than sequentially. And then once I find some segments, realize that I'm going to then try to place my second MCP right up against that spinous process, or the spinous process that's lower than the stuck segment. Once I have that set up, right, then I'm going to rotate away, laterally flex towards, but we're talking about kind of bending her head or bending her neck over that second MCP, and then once she's there and I'm nice and locked up, take a deep breath. I can give her a quick little rotation and lateral flexion thrust. So this, and if she's locked up properly and we hadn't just manipulated in the previous take of this video, which you guys saw, she probably would have gotten a cavitation on that one. But keep in mind that cavitations don't mean success. Changes on reassessment mean success. Guys, I hope you found this video very helpful. Grab some friends and practice, and if you have any questions, leave them in the comments box below. A couple of points to recap. Knowing your anatomy and knowing your biomechanics will certainly help you choose the right technique for the right patient. If you're unsure whether manipulations are appropriate due to their higher intensity, it's okay to do mobilizations. Most research points to manipulations being slightly more effective, but mobilizations being very effective. And of course, we have those videos for you if you want to start with those less intense techniques. Make sure that if you are doing any technique that is based on assessment, and of course that you're reassessing, ensuring that the technique is effective for the patient that you're working on. And when it comes to all manual techniques, guys, manipulations, maybe more than any other, look for opportunities to get live education. Although I know videos are convenient and I'm happy to have these up for you guys to watch, it would be so much more helpful to use those videos as a recap of one-on-one attention with somebody who's experienced with manipulation techniques. At the very least, grab a colleague, grab a friend, and start practicing these before you bring them into clinic and start using them on patients and clients. I hope you enjoyed this video. If you have any questions, please leave them in the comments box below.